What happens when your lung suddenly collapses without warning? It's called a pneumothorax. Today, we're breaking down the science of trapped air, the difference between primary and secondary cases, and the one type that is a true medical emergency.
A pneumothorax is simply the presence of air within the pleural cavity. Under normal conditions, this space is a vacuum. When air enters, it puts pressure on the lung, preventing it from expanding fully.
The condition is broadly categorized into two types based on the cause. First is spontaneous pneumothorax, occurs suddenly without an obvious injury. It is further divided into primary, when it occurs in people with no known lung disease. Secondary, occurs as a complication of an existing lung disease. Second is traumatic pneumothorax, which is caused by a physical injury. Like non-iatrogenic, which is caused by external trauma, like a car accident or a wound. And iatrogenic, which is caused accidentally during a medical procedure, like a biopsy. First is open pneumothorax. Here air moves freely in and out of the chest cavity as the person breathes. Second is closed pneumothorax. In this case the hole, or communication closes. Since no more air is entering, the body slowly reabsorbs the trapped air, and the lung can re-expand on its own. Third is tension pneumothorax, which is a medical emergency. In such patients a one-way valve forms. Through this valve air enters the chest when breathing in but cannot get out. This creates high pressure that crushes the lung and can even push the heart and major blood vessels to the opposite side of the chest, which is called as mediastinal shift. Causes of pneumothorax. First is primary spontaneous cause. It occurs in people without known lung disease. The main cause, about 90%, is apical blebs, which are air-filled blisters on the top of the lungs. And the certain body types that is their stature. Second is secondary spontaneous cause. It occurs as a complication of an existing lung disease, such as COPD like bronchitis and emphysema, asthma and infections like pneumonia or TB. Third cause is traumatic iatrogenic, which is caused by medical procedures, such as inserting a central line, lung biopsies, or being on a ventilator. Fourth is traumatic non-iatrogenic cause. It is caused by external injury, such as car accidents, stab wounds, or broken ribs. Symptoms of pneumothorax. How a patient of pneumothorax feels can vary based on the size of the collapse. If small collapse, it often has no symptoms. Common symptoms like sudden, sharp chest pain on one side and shortness of breath. The pain often gets worse when breathing deeply or moving. If the lung collapse is large, the patient may show signs of shock, anxiety, rapid breathing that is tachypnea, and low blood pressure. Physical signs of pneumothorax includes 1. Breath sounds are missing or very quiet on the side of the collapse. 2. The affected side doesn't move as much when the patient breathes. 3. When tapping the chest, it sounds hyperresonant, that is hollow or drum-like sound on percussion because of the trapped air. 4. Shift of mediastinum seen in severe cases, the heart and trachea are pushed toward the healthy side. 5. Vital signs shows increased neck vein pressure, that is JVP, cyanosis, and sweating. 6. Crepitus heard, which is a crunchy feeling under the skin if air has escaped into the tissues. We diagnose pneumothorax on ECG and X-ray. ECG may show a decrease in the QRS amplitude. Chest X-ray is the primary diagnostic tool. It shows a sharp lung edge curved outwards, separated from the chest wall by a dark area that is translucency that has no lung markings. In severe cases, the heart and middle chest structures, that is mediastinum, may be pushed to the opposite side. Complications of pneumothorax includes recurrence, that is if not treated correctly, it can happen again and again. Bleeding or infection in the chest cavity, that is hemopneumothorax or pneumothorax. And respiratory failure. Pneumothorax treatment depends on how large the collapse is and how the patient feels. If lung collapse is small and patient is asymptomatic, it may resolve on its own. If lung collapse is small but patient is symptomatic, then patient is given high-flow oxygen to help the body reabsorb the air. If lung collapse is large, over 15 to 20%, it requires a thoracostomy tube to drain the air. In emergency situations like tension pneumothorax, which is life-threatening, it requires immediate decompression using a 14-gauge needle to let the air out before a chest tube is placed.